Hello and welcome to The Explainer. Today, we're diving into something called gastric varices. Now, these are swollen veins in the stomach, and they can cause some really life-threatening bleeding. The good news is, modern medicine has developed a clear roadmap for managing this risk, and we're going to walk through it step by step. Okay, so let's get right to it. This number, 45%. This is why we're having this conversation. In some studies, this is the high-end mortality rate for a bleeding gastric varix. That is a huge number. It really drives home just how serious this can be, and why having a solid plan is absolutely non-negotiable. All right, so here's our game plan. We'll start by looking at the hidden risk these varices pose. Then we'll dig into the pressure problem that actually creates them in the first place. After that, we're going to look at how doctors map out these veins. And once we have that map, we'll open up the medical toolkit, see how the right treatment is chosen, and wrap up with why a team approach is the key to success. So, first things first, we have to understand what makes these gastric varices so uniquely dangerous. You see, they aren't as common as the ones you hear about in the esophagus, but when they do bleed, oh boy, it's often a much bigger deal. And that's really the heart of the issue. You know, only about 20% of patients who have high pressure in their liver's blood supply, that's a condition called portal hypertension, only about 1 in 5 will get these specific varices in the stomach. But, and this is the part you really got to remember, the bleeding is typically way more severe. They just pack a much bigger punch. So what's actually causing this? To figure that out, we've got to look at the engine driving the whole thing. It all comes down to a condition called portal hypertension. It is, quite simply, a pressure problem. So what is portal hypertension really? Well, think of it this way. It's just too much pressure inside the veins that carry blood from your gut and spleen to your liver. Usually, something like liver cirrhosis acts like a dam, blocking that blood flow. And when the flow is blocked, pressure backs up behind it. It's a pretty straightforward idea, but man, it leads to some complicated problems. You know, here's the best way to picture it. Imagine the main vein to the liver is a 6-lane superhighway. Now, what if there's a huge crash that shuts the whole thing down? Well, all that traffic, the blood, it's got to go somewhere. So it gets forced onto these tiny little side streets. Those are the varices. And those streets were never, ever built to handle that kind of volume. Sooner or later, they're going to blow out. Okay, so if we're going to fix these dangerous little side streets, we first have to know exactly where they are, where they're coming from, and where they're going. This is the mapping phase. And when it comes to this condition, a patient's unique anatomy, well, it's basically their destiny. Now, this mapping uses two totally different points of view. On one hand, you've got an endoscopy, where a doctor puts a camera down and literally sees the surface of the varix inside the stomach. But on the other hand, you have advanced imaging, like a CT scan, and that gives you the full blueprint. It shows the veins feeding in and the veins draining out. It's like the difference between seeing the tip of an iceberg and actually seeing the whole massive structure underneath the water. And that's the whole point, right? Creating this blueprint, it isn't just some cool academic thing to do. It is, without a doubt, the most important step for deciding how to treat that specific person. You're flying blind without this map, but with it, you can design a really precise, really effective plan. All right, so once that map is drawn, the medical team gets to open up their toolkit. And it's a pretty amazing toolkit with 3 main strategies for dealing with these dangerous varices. So let's look at the big 3. First, you've got ECI. That's endoscopic cyanoacrylate injection. You can basically think of it as medical superglue that gets injected right into the varix to seal it off. Then there's TIPS. This is a bigger deal. It's a procedure that creates a brand new highway, a shunt, inside the liver to relieve all that pressure. And finally, there's RTO, which is this really clever technique where they go in through the back door of the varix to plug it up. Let's break down how RTO works, because it's pretty cool. It's basically a 3-step process. Step 1. An interventional radiologist threads a tiny catheter into the main vein that's draining the varix. Step 2, they put something in there, like a little balloon or a metal plug, to block that exit route. And finally, step 3, with the exit blocked, they inject a substance backward, filling up the varix and causing it to clot off completely. Job done. And what's really neat is that this technique just keeps getting better. The original version, BRTO, used a balloon that had to stay inflated inside the patient for hours. But the newer methods like Parto and Cardo use permanent plugs or coils instead. This makes the whole procedure way faster and safer. It's a perfect example of how medicine is always innovating. So we have a detailed map, and we have a sophisticated toolkit. This is where it all comes together. How do doctors actually pick the right tool for the job? Well, they follow a really logical decision tree. Everything starts with this one question. It's the most critical one, and you can only answer it with that detailed CT or MR scan we talked about. The question is there a big, easy-to-get-to, draining vein, what's called a gastrorenal shunt, or GRS? If the answer is yes, well, the path forward is pretty clear. Having that GRS is like having a perfectly paved access road straight to the problem. It makes RTO the most direct, most elegant way to go and just plung that varix up. But what if there isn't a GRS? Then the decision tree splits. The very next question is, okay, are we just dealing with this one problem varix, or is the patient suffering from other big issues because of the portal hypertension, like a belly full of fluid or other dangerous varices in their esophagus? If it turns out the whole system is overloaded and causing multiple problems, then you need a system-wide solution. That's when TIPS becomes a really strong option. It tackles the root cause by lowering the overall pressure. It fixes the big traffic jam on the main highway instead of just patching up one little side street. And finally, if there's no GRS, and the varix really is the only major problem on the table, then sometimes the most direct approach is the best. And that's when the team will likely turn to ECI, the endoscopic superglue, for a super targeted, very localized fix. This all leads us to our final point, and honestly, it might be the most important one. Tackling gastric varices is not a one-person job. It is absolutely a team sport, and it takes incredible collaboration to get it right. And look, the source material says it perfectly. Success here needs a true team effort. You need the liver doctors, the hepatologists who manage the underlying disease. You need the therapeutic endoscopists who can go in with a scope. And you need the interventional radiologists who are reading those maps and doing procedures like RTO. At the end of the day, success depends on every single one of them working together. So we've seen this incredible evolution, right? From a really high mortality event to something that can be managed with a clear plan. It's just an amazing story of medical progress. And it leaves us with this one final, really exciting thought. As these tools get even better and more precise, could we actually get to a point where we move beyond treatment and into true prevention and stop these dangerous bleeds before they even have a chance to start?